Have you ever found yourself in a hospital, maybe for a quick visit or a longer stay?
Mm-hmm.
You see the doctors, the nurses, all the technology. But have you ever paused to think about the intricate, often invisible layers of safety, quality, and, well, meticulous planning that must be there working behind the scenes?
Yeah, it's true. Or maybe you've noticed when those layers weren't there, which can be quite concerning.
Exactly.
We often take for granted the complex systems that, transform a hospital from just a collection of buildings and equipment into a functioning, patient-centered entity.
Right.
It's easy to focus on the immediate care, the doctor you see, but there's this whole foundational framework underneath, making sure everything operates smoothly, ethically, and most importantly, safely.
Okay, let's unpack this then. Today, we're doing a deep dive into something incredibly important, but honestly, often unheard of by the general public.
Mm-hmm.
The National Accreditation Board for Hospitals and Healthcare Providers.
Or NABH for short.
NABH, yes.
Yeah.
It's a name you might not hear every day, but it is absolutely critical to the quality and safety of healthcare in India. And frankly, it sets a global benchmark for what high-quality care really looks like.
Definitely. Our mission for this deep dive really is to pull back the curtain on how hospitals evolve, how they go beyond just being facilities with medical gear into truly safe, ethical, and patient-centered healing environments. We'll be extracting the most important nuggets of knowledge from a comprehensive guide to NABH standards.
And revealing how every single touch point of your care journey, from walking in the door to leaving, is meticulously designed and monitored.
Exactly. The aim is that by the end of this, you'll gain a whole new appreciation for the sort of unseen architecture that goes into truly high-quality healthcare.
So let's kick things off with the absolute basics then. What exactly is NABH and why was it established in the first place?
Okay, so at its core, NABH is a constituent board of the Quality Council of India, or QCI.
QCI, right.
It was established back in 2005. It was a joint initiative, really, between the government of India and various Indian industries.
Okay.
Its primary purpose is to ensure quality healthcare across the nation. And it does this through a pretty rigorous process of accreditation and certification.
So it's India's main body for setting and enforcing these high standards in healthcare.
That's a good way to put it, yes. It's the key player.
Now, what's truly fascinating, and you mentioned this briefly, is that NABH isn't just for those huge multi-specialty hospitals we often picture. Its scope is, well, surprisingly broad, isn't it?
Absolutely, and that's one of its most impactful aspects, I think. Its reach is wide. It provides accreditation to a really diverse spectrum of healthcare facilities.
Like what specifically?
Well, it's not just the big corporate hospitals. It extends to smaller clinics, vital blood banks, AYUS-shaped centers.
We focus on traditional Indian medicine, right? Ayurveda, yoga.
Exactly. Ayurveda, yoga, Unani, Siddha, homeopathy, also dental clinics, wellness centers, you name it. There's a whole range. And this broad scope means that the push for quality standards isn't just stuck in a few elite institutions. It's actually permeating or trying to permeate the entire healthcare ecosystem.
So it's about raising the bar everywhere, not just at the top.
Precisely. It aims to build a consistent baseline level of quality and safety, regardless of whether it's a small clinic or a large hospital. Size or specialty shouldn't dictate basic quality.
And the source material really emphasizes this isn't just about getting a certificate to hang on the wall. It's much deeper than that.
Oh, absolutely vital to understand. The guide describes NABH accreditation not just as a badge, but as a comprehensive, evidence-based framework for building hospitals that are safe, ethical, patient-centered, efficient, and continuously improving.
That sounds like a massive undertaking.
It is. It's not a one-time audit checklist you just tick off. It's about fundamentally designing and embedding quality into the hospital's day-to-day operations. It's culture.
So it demands real, systematic change.
Yes. It requires looking at every single process, how a patient is admitted, how meds are handled, how instruments are sterilized. Everything has to adhere to these high standards.
That sounds incredibly rigorous. So how does this whole system actually work in practice? How does NABH implement this?
It works through a very structured, multi-step process. First, NABH develops these incredibly detailed standard manuals. For example, there's the 6th edition specifically for hospitals.
And these manuals cover everything.
Pretty much. They lay out comprehensive requirements across virtually every aspect of hospital care. Think of it like the ultimate blueprint for operational excellence. It details everything from clinical protocols to infrastructure safety requirements.
Okay. And you mentioned accreditation is voluntary for hospitals.
Yeah.
But once they decide to go for it, there's no half-stepping.
That's correct. While initiating the process is voluntary, once a hospital chooses to pursue NABH accreditation, their commitment to comply with all applicable standards becomes absolute.
All of them. No picking and choosing.
None. You're in for the whole package. And to ensure this, NABH deploys trained assessors.
And these aren't just auditors.
No, they're not just box tickers. They are experienced clinicians, administrators, quality experts. They conduct thorough on-site evaluations. They review documentation meticulously, interview staff at all levels.
Really getting under the hood.
Exactly. To verify that the standards aren't just on paper, but are truly being implemented in the day-to-day reality of the hospital.
And it's not a one-and-done deal either, is it? I read there's a continuous cycle involved.
Precisely. Accreditation isn't permanent. It's typically granted for a period of 3 years.
3 years, okay.
But the oversight doesn't stop there. This is key. Crucial surveillance audits are conducted during this 3-year cycle.
So they check in.
Yes, to ensure ongoing compliance. It means a hospital can't just, gear up for the main assessment, get accredited, and then let things slide.
Right, prevents complacency.
It fosters a culture of continuous readiness and ongoing improvement. It has to become part of their DNA.
What's also fascinating is that NABH isn't just an Indian standard operating in isolation. It has significant global recognition. How does that aspect work?
That's a really key differentiator. NABH has an affiliation with ISQA, the International Society for Quality in Healthcare. It's now known as the IEEA. The International Society for Quality in Healthcare External Evaluation Association. Bit of a mouthful.
Yeah.
But ASQA, or AEA, is the global body that actually accredits the accreditation bodies themselves, like the accreditors of accreditors.
Oh, okay. Meta.
Exactly. Yeah. So by being affiliated with and accredited by IEA, NABH itself is recognized as meeting international best practices for accrediting healthcare organizations.
So the standards NABH promotes in India, they hold up internationally.
They do. It means that an NABH-accredited hospital in India is meeting standards that are recognized and respected on the global stage. It makes them competitive and trustworthy internationally, which is huge.
Okay, let's connect this to the bigger picture then. Why does NABH matter so much in today's healthcare environment? Because, honestly, for a lot of us, we probably just assume hospitals are safe. Right.
It's a fair assumption, but perhaps a bit simplistic today. Today's healthcare environment is vastly more complex than it used to be, and patient expectations are, quite rightly, incredibly high.
So being good clinically isn't enough anymore.
Clinical skills are absolutely fundamental, non-negotiable, but they're simply not enough on their own anymore.
What else are patients demanding?
Well, think about it. Patients today demand transparency, especially in billing. They want a clear understanding of their treatment plan. They demand and deserve absolute safety from errors and infections. They want to be treated with dignity, experience continuity of care, a smooth journey from admission to discharge, and they need to rely on hospital systems that simply don't fail them, especially in emergencies.
And NABH directly addresses these demands.
It does. It provides the framework to meet all these evolving expectations systematically.
So let's bring it down to the individual. What does this all mean for you, the patient? How does NABH build that crucial trust?
It builds trust by helping institutions standardize their processes, by forcing them to systematically identify and eliminate unsafe practices. Ultimately, it's about creating reliable systems.
Okay.
When a hospital achieves NABH accreditation, it signals to you, the patient, that this facility has voluntarily subjected itself to a really rigorous external evaluation.
It's like a seal of approval.
In a way, yes. It means they've met stringent, high standards for quality and safety across virtually every single aspect of their operation. It's a mark of assurance.
And the benefits aren't just for the patients, are they? The hospital must gain something too.
Oh, absolutely. The benefits are truly comprehensive. For patients, as we said, it means improved clinical outcomes, a demonstrably safer experience, and enhanced trust and satisfaction. For the hospital itself, it leads to much better documentation. That might sound boring, but it's crucial for safety. It also vastly improves team coordination, making sure everyone involved in your care is on the same page.
Which prevents errors.
Exactly. It also ensures legal and regulatory compliance, which is vital for any healthcare institution's survival. The national and global recognition is a huge plus for the hospital's reputation, attracting patients and staff.
And for the staff themselves.
It creates safer working conditions, better morale, potentially better staff retention. And perhaps most importantly, it fosters this continuous quality improvement culture.
Meaning they're always looking to get better.
Always looking for ways to refine processes, reduce risks, improve outcomes. So what does this all mean in the end? It means a better, safer, more reliable experience for you, the patient, and a more effective, efficient, and ethical operation for the hospital. It's a win-win.
Okay, that gives us a really solid understanding of NABH's foundations. Now that we've got a handle on what it is and why it matters, let's move into the actual patient journey. How do these standards play out step by step, starting right from when a patient first interacts with the hospital?
Right. This first part focuses on access, assessment, and continuity of care, often abbreviated as AAC.
AAC, okay.
And our guide uses a really vivid analogy here, which I like. Think of a hospital visit like a road trip.
Okay.
Access is finding the car, assessment is checking the fuel and map, continuity is making sure someone's driving with you the whole way.
That makes sense. Access, assessment, continuity, finding the car, checking the map, having a co-pilot.
Exactly. The core idea is that great AAC means no one ever feels lost, confused, or unattended during their hospital journey. It's about ensuring you get timely, safe, and coordinated care from the moment you say hello to when they say see you soon.
So let's break that down. How does a hospital make that first impression count? Making it easy to actually get in, get registered, and understand your basic rights as a patient.
This first standard really covers that initial welcome and ensuring transparent patient rights. In practice, this isn't just about having a front desk.
It's more than that.
Oh yeah. It means having big, clear signs guiding you from the entrance. Accessible ramps for wheelchairs or walkers, maybe a greeter or an obvious help desk right when you walk in.
Reducing that initial confusion and anxiety.
Precisely. Registration forms should be simple, easy to understand, asking only for essential info name, contact, maybe insurance details, and critically, patients need to receive clear information right away.
About their rights.
Yes. Whether it's through leaflets, posters on the wall, ideally in local languages explaining things like privacy rights, the process for informed consent, and crucially, their right to ask questions or even refuse treatment.
So empowering the patient from minute one.
Exactly. It's about guiding every visitor from feeling potentially lost and vulnerable to feeling registered, informed, and somewhat oriented within minutes. Making that first touch point smooth and transparent is key.
Okay, so you're in the door, you're registered, you know your rights. Then you immediately get assessed, right, Bart? How thorough is that initial checkup, and does that assessment continue throughout your stay?
Absolutely. The standard requires that every patient gets a thorough check-in upon arrival and then ongoing evaluation throughout their stay. It doesn't stop after admission.
What does that initial check involve?
It starts with an initial snapshot, as the guide calls it, quickly gathering key details: name, age, the reason you're there, any known allergies, current medications.
The basics.
The critical basics. Then taking vital signs, temperature, pulse, blood pressure, respiratory rate, and getting a quick history of past illnesses or relevant conditions.
And then it continues.
Yes. What's critical here is the idea of continuous monitoring. This isn't just a one-off assessment. It involves scheduled checks, like assessing pain scores regularly, repeating vital signs at set intervals, all with clear, consistent documentation.
So the care team always has the latest picture.
Exactly. It's about capturing a full health picture at arrival and then continuously updating it so the entire care team always has the most current, relevant information to make decisions.
So if everyone has the latest picture, that sounds like it leads directly into coordination. How do hospitals make sure all the different teams, doctors, nurses, labs, therapists, are working from the same playbook? How is that patient story kept unified?
That's the essence of continuity and coordination of care. The goal is precisely that, ensuring all the teams involved share one single, unified, up-to-date patient story.
How do they achieve that in practice?
Several ways. Unified patient files are key, whether they're paper charts or increasingly digital electronic health records, EHRs. These need to have timestamp notes so everyone knows the latest entry and who made it.
Okay.
It also involves communication practices like quick huddle meetings. These might happen when patients move between departments, say from the emergency room to a ward, or during shift changes between nursing teams.
So everyone gets briefed.
Yes. And the aim is to have a single, coherent care plan. This plan should map out planned tests, medications, therapies, and clearly assign ownership who is responsible for doing what, and when.
Like that relay race analogy you mentioned earlier.
Exactly. It's like a relay race where every runner clearly sees the finish line and knows exactly who has the baton right now.
Okay.
The goal is smooth handoffs and no dropped batons, which in healthcare could be critical information.
And speaking of handoffs, especially during shift changes or transfers between departments, that sounds like a really critical point for potential errors. How do hospitals ensure that information transfer is safe and nothing gets missed?
It is an incredible critical safety point. NABH standards require that every time care responsibility passes from one caregiver to another, there must be a formal, structured handover process.
Not just a quick chat.
Definitely not. In practice, this often means using standardized communication tools. A common one is SBAR.
SBR.
Situation, background, assessment, recommendation. It provides a structured way to convey the most critical information concisely and clearly. It also encourages face-to-face briefings whenever possible, and many hospitals require readbacks, where the incoming staff member repeats key orders or critical information back to the person handing over.
To confirm understanding.
Precisely. It's about passing that baton deliberately, clearly, and confirming that the next person has caught it securely. It eliminates assumptions and misunderstandings that can lead to serious errors.
Okay, so the patient journey continues. They receive care, and eventually it's time to leave. How do hospitals make sure patients are truly ready to go home, that they have all the information they need for continued recovery?
This standard focuses on effective discharge planning and instructions, and a key point the guide makes is that discharge planning ideally begins on day one of admission, not hastily thrown together on the last day.
Starting early makes sense.
It allows for a more thoughtful and comprehensive plan. Before a patient leaves, they must receive clear, actionable plans. This covers medications, what to take, when, how, follow-up appointments, when and where, and critically, warning signs, what symptoms should prompt them to seek help again.
How is this information given?
It should involve both verbal counseling, where someone sits down and explains it, and simple, easy-to-read written leaflets. Ideally, these leaflets are in local languages. Hospitals should also try to schedule the next appointment or lab test for the patient before they leave, reducing that burden. And providing a helpline number for questions that pop up later is also best practice.
So it's a supported transition.
Exactly. The guide puts it nicely. Discharge is see you soon, not goodbye. It's about ensuring a smooth, well-supported transition back home with clear guidance for continued recovery and knowing who to call if needed.
And finally, for this AAC section, what if a patient needs specialist care or maybe community-based rehab after discharge? How do hospitals ensure those referrals are seamless and the care continues?
This standard is about referral and follow-up, ensuring those transitions outside the hospital are smooth. It involves using standardized referral forms that concisely summarize the patient's history, their hospital stay, and the specific reason for the referral.
So the specialist gets the needed info.
Yes, clearly and efficiently. Ideally, the hospital helps pre-book those specialist slots or rehabilitation appointments before discharge, again, removing a potential barrier for the patient.
That's helpful.
And crucially, there should be a feedback loop established. The specialist or community service should report back to the hospital on the patient's progress or findings.
Closing the loop.
Exactly. It keeps it one continuous journey of care, not two disconnected trips where information gets lost in between.
Okay, that's a lot of detail on access, assessment, and continuity.
Yeah.
Let's walk through that real-world example to see how it all fits together. The guide provides the case of Mrs. Mira.
Right. Mrs. Mira's visit illustrates these AAC standards really well. She comes in with chest pain.
Okay.
Thanks to clear signs at the entrance and a priority triage system in the ER, she's registered and seen by a doctor within just a few minutes. That's excellent service access.
Fast and efficient.
Then, the team quickly records her vital signs, gets her history, noting her diabetes and hypertension orders and ECG, and logs everything into her digital chart. That demonstrates thorough, initial, and ongoing patient assessment.
Got it.
Cardiology sees her results on their system even before she physically arrives in their unit. They admit her and coordinate consults with the dietitian and physiotherapist right away. That's seamless continuity and coordination of care in action.
Whole teams working together.
Exactly. Later, during a shift change, Nurse A uses the SBAR tool situation, background, assessment, recommendation to brief Nurse B on Mrs. Mira's medications, pending labs, and potential risks. That's a formal transfer of accountability.
Clear handover.
On day 3, before she leaves, Mrs. Mira receives a printed care plan, but importantly, it's in Malayalam, her local language. She gets verbal counseling on meds and warning signs, and her follow-up appointment is already booked. That's good discharge planning instructions.
Tailored to her needs.
And finally, she's linked to a local cardiac rehab center. The hospital has arranged it, and the center agrees to send progress notes back to the hospital cardiologist. That illustrates seamless referral and follow-up.
Wow. So that whole sequence shows how these individual standards work together in harmony to provide comprehensive, safe, and coordinated care from start to finish.
Precisely. When AC works well, the patient journey feels much smoother and safer.
That was an incredibly detailed look at the entry and flow. Now let's pivot to the core of what happens once someone is admitted. The actual care of patients, or COP.
Yes, COP is really the heart of inpatient care. It's a big chapter covering, well, pretty much everything we do for the patient once they're inside the hospital walls.
Like what specifically?
It starts with welcoming them properly and making sure they're correctly identified always. It covers explaining procedures and getting truly informed consent. It deals with providing appropriate nutrition and hydration, managing medications safely, controlling pain effectively. It also includes ensuring access to necessary diagnostic tests, robust infection prevention practices, the careful and ethical use of restraints if absolutely necessary, and providing compassionate end-of-life care. It even covers the dignified handling of the deceased.
So it's incredibly comprehensive.
It is. The overarching goal of Great COP, as the guide puts it, is to transform what could be a scary, confusing, overwhelming hospital stay into an experience that feels safe, dignified, and genuinely healing.
Okay, so once a patient is admitted to a ward, how do hospitals ensure that care is precise and personalized right from the get-go?
It really starts with rigorous admission, identification, assessment, and care planning. From the moment you arrive on the ward, staff must rigorously confirm your identity. Often by asking your name and date of birth and critically cross-verifying this against an identification wristband the patient wears. This happens before any procedure or medication.
Double-checking.
Always. Simultaneously, a more detailed baseline assessment is performed by the nursing and medical team. Based on this, a personalized care plan is developed.
What's in the care plan?
It defines specific, measurable goals, like maybe patient will immobilize with assistance by day 2 post-op, and it assigns clear responsibilities. What the nurse will do, what the physiotherapist will do, what the dietitian will monitor.
So it's a roadmap.
Exactly. Clear ID combined with a detailed roadmap makes for a smoother, safer journey through the hospital stay.
And a crucial part of that journey involves procedures or treatments. How do hospitals handle informed consent to ensure patients truly understand what they're agreeing to?
This is absolutely fundamental. It's a core patient right. Before any significant procedure or treatment, patients must fully understand the potential risks, the expected benefits, and any available alternatives. And then they must agree, usually in writing.
How is that explanation done effectively?
The standard emphasizes using simple, jargon-free language. Instead of complex medical terms, explain it plainly. This scan takes about 10 minutes, you'll hear some noise, and the dye might make you feel warm for a moment.
Makes sense.
It's often a 2-step process. A thorough verbal explanation by the doctor or nurse, allowing time for questions, followed by the patient signing a consent form.
And can patients change their mind?
Critically, yes. Patients always retain the right to withdraw consent or change their mind at any point, even after signing the form. Informed consent is truly meant to be an ongoing conversation, not just a one-time checkbox exercise.
The principle being, no decision about me without me.
That sums it up perfectly. Patient autonomy is paramount.
Okay, beyond specific consent for procedures, how do hospitals ensure patients are continuously informed about their general rights within the hospital and educated about their condition and ongoing care?
This standard covers patient rights, information, and education on an ongoing basis. Patients need to receive a clear rundown of their rights. The right to privacy, the right to seek a second opinion, how to voice a concern or complaint using the grievance redressal system.
How is this information provided?
Often through multiple methods. Posters on the walls, leaflets given at admission again, ideally in local languages, sometimes even in Braille or audio formats for accessibility. Staff might also verbally reinforce these rights.
And the education part.
Beyond rights, patients need what's next education. Simple leaflets explaining things like how to care for your IV site or why your physiotherapy exercises are important.
Practical tips.
Exactly. And a key practice here is using the teach-back method,
Teach-back.
where staff ask patients to explain the instructions back in their own words. It's a great way to confirm understanding, much better than just asking, do you understand?
Yeah, people often just nod.
Right. The goal is that informed patients become empowered partners in their own care journey.
Makes sense. Now, of course, two absolute fundamentals for healing are nutrition and medication. How do hospitals manage these critical aspects safely and effectively under the COP standards?
They're crucial. For nutrition and hydration, hospitals must assess each patient's dietary needs. Are they diabetic? Do they have swallowing difficulties? Allergies? And then deliver safe, appropriate, and hopefully tasty meals and fluids.
So, personalized diets.
Yes, based on the doctor's orders. This means providing specific diet charts, regular, diabetic, low salt, soft diet, etc. And critically, staff must provide mealtime assistance for patients who need help eating or drinking. Good nutrition and proper hydration are fundamental fuels for healing.
And for medication management within COP, we'll dive deeper later, but what's the core principle here?
The core principle here is ensuring the right drug, right dose, right route, right time, and right patient every single time. This is often called the 5 rights of medication administration.
The 5 rights, okay.
Hospitals implement rigorous checks before giving any medicine. Many use barcode scanning at the bedside now or other double-check systems to significantly reduce errors. And staff are required to provide patient teaching about their meds, explaining the name, purpose, and key side effects to watch for. Safe medications are foundational to safe patients.
Absolutely. Now, managing pain, it's not just about comfort, is it? It's actually a critical part of recovery. How do hospitals approach pain management proactively?
You're right. It's much more than comfort. Pain is often recognized as the 5th vital sign, alongside temperature, pulse, breathing rate, and blood pressure. It must be measured and treated proactively, not just when a patient complains loudly.
How is it measured?
Hospitals use standardized pain scales. The most common is the 0 to 10 numerical scale, where 0 is no pain and 10 is the worst imaginable. Sometimes Faceless scales are used, especially for children or those who can't verbalize easily.
And treatment?
They employ multimodal relief. That means combining different approaches, pain medications, yes, but also non-pharmacological techniques like applying ice packs for heat, relaxation exercises, distraction.
Holistic approach.
Exactly. And crucially, staff must reevaluate frequently, asking, did that medicine help? Is your pain better now? And adjusting the plan accordingly. Controlling pain effectively speeds recovery, improves mood, and allows patients to participate more actively in things like physiotherapy.
Makes perfect sense. Now, access to diagnostic services, labs, x-rays, scans is also vital for timely diagnosis and treatment. How do hospitals ensure quick and safe access to diagnostic and therapeutic services?
This standard ensures that necessary services like lab tests, x-rays, ultrasounds, CT scans, or even physiotherapy sessions are available without unsafe delays.
How do they manage that flow?
It involves effective scheduling and coordination. Pre-booking slots based on clinical priority emergencies obviously come first, then urgent cases, then routine ones. There needs to be coordination for patient transport, especially for bedridden patients, ensuring porters or wheelchairs are available.
Okay.
And critically, ensuring the timely communication and sharing of test results back to the treating doctor and care team is essential. Fast tests plus clear reports, on time, appropriate treatments. Delays here can delay crucial care decisions.
Another critical aspect we hear a lot about is infection prevention and control. We'll dive deeper later, but how does COP address protecting patients from hospital-acquired infections?
Within COP, the focus is on the direct application of IPC practices at the patient level. This means stopping germs in their tracks to protect both patients and staff during care delivery.
What does that look like practically?
It means things like ubiquitous hand hygiene stations, gel dispensers, or sinks readily available at every bedside and point of care. It requires strict adherence to sterile techniques during procedures like inserting IV lines or changing dressings, and having clear isolation protocols for patients with contagious infections.
So basic hygiene is key.
Absolutely fundamental. A clean environment, clean hands, clean equipment. It's the bedrock of safe care. Additionally, COP standards cover the appropriate and minimal use of restraints, ensuring they're only used as a last resort, under strict protocols, prioritizing patient dignity.
Right.
And it also includes comprehensive, compassionate protocols for end-of-life care, focusing on comfort and dignity when cure is no longer the goal, and respectful procedures for the handling of the dead body, maintaining dignity even after death.
Okay, let's bring this all to life again with the example from the guide, Mr. Ravi's hip replacement. How does his journey illustrate these COP standards?
Mr. Ravi's experience is a great showcase. Upon admission to the ward, staff double-check his identity using his wristband before starting any care that's identification. Before surgery, the anesthetist sits down, explains the risks and options for anesthesia, answers his questions, and gets his signature on the consent form that's informed consent done right.
Good start.
He's immediately put on a high-protein diet plan by the dietitian to support tissue healing that's proactive nutrition. Post-surgery, pain nurses check his pain score every few hours using the 0-10 scale, adjust his high-V pain medication based on his score, and also teach him deep breathing exercises that's comprehensive pain management and medication management. His post-op x-ray and first physiotherapy session slots are pre-booked before he even leaves the OR, and porters are scheduled to wheel him safely to the x-ray department, demonstrating good access to diagnostic and therapeutic services.
Smooth transitions.
In the OR, everyone scrubs in meticulously, wears sterile gowns and gloves. His surgical wound dressings are changed, using a strict sterile technique on the ward embodying infection prevention and control.
Crucial for surgery.
And when he's a bit drowsy and confused post-op, instead of using physical restraints, the nurses activate a bed alarm that alerts them if he tries to get up unsafely. This reflects the standard on use of restraints, prioritizing the least restrictive measure, and maintaining dignity.
That's a great example of thoughtful care.
Exactly. This whole sequence, ID checks, consent, nutrition, pain control, diagnostics, infection prevention, thoughtful safety measures, shows how these COP standards work together to create a structured, safe, and patient-centered healing experience, even during something as major as a hip replacement.
That brings us perfectly into part 3, where we take a deeper dive into 2 absolutely critical safety areas we just touched upon: management of medication, MOM, and infection prevention and control, IPC. Let's start with the complexities of medication.
Right. Medication management is incredibly high risk if not done properly. The guide uses another brilliant analogy here. Think of medication in a hospital like fuel for a jet engine.
Okay, I like that.
Yeah.
Fuel for a jet engine.
It breaks down the whole process. First, selection, deciding which fuels, drugs, are safe and effective to keep on board. This involves creating a hospital formulary or approved drug list. Then storage, keeping the fuel in the right tanks at the right temperature securely, prescribing the flight plan, detailing exactly which fuel, how much, when, dispensing, getting the right fuel accurately measured and ready.
Got it.
Administration, actually putting the fuel into the engine correctly at the right time, monitoring, checking engine performance and fuel levels during the flight. And finally, reconciliation, ensuring the fuel logs match up during refueling or crew changes.
Wow, that analogy really highlights the precision needed at every step.
It does. The key takeaway is that great MOM saves lives by preventing errors, delivery delays, and dangerous drug interactions. One mistake in this chain can have catastrophic consequences, just like with jet fuel.
So it's clearly not just about the nurse giving the right pill. It's this entire intricate journey of that medication through the hospital system. How do hospitals ensure this whole chain is safe according to MOM standards?
It truly is a multi-layered system approach. First, you need a safe pharmacy and medication management structure. This means having a designated medication safety officer or committee overseeing all protocols. The pharmacy itself must be adequately staffed with trained pharmacists and technicians and operate under strict procedures.
The foundation.
Yes. Then comes formulary management. The hospital must maintain an up-to-date list of approved medications, the formulary. This isn't static. It should be created and regularly reviewed by a multidisciplinary committee, doctors, pharmacists, nurses, based on efficacy, safety, and cost-effectiveness. Clinicians need easy access to this list, and there must be a clear process for requesting non-formulary drugs when clinically essential.
Like a curated menu.
Exactly, a carefully curated and regularly updated menu. Next is storage of medications. This is critical. Meds must be stored properly to maintain stability. Think refrigerators for vaccines and certain antibiotics. They need to be secure, locked cabinets for narcotics and other controlled substances, and high alert medications.
High alert? Like what?
Drugs like insulin, heparin, concentrated electrolytes, drugs that have a high risk of causing significant harm if used in error. These need to be stored separately or with special labeling to prevent mix-ups. The right drug needs to be available where needed, like in emergency carts, but stored safely.
Makes sense. Then comes prescribing.
Safe and rational prescribing is paramount. Prescriptions must be accurate, complete, legible, and clinically justified. Doctors need systems to check for patient allergies before prescribing. Digital prescribing, CPOA computerized provider order entry, is preferred as it avoids legibility issues. If handwritten, orders must be in clear capital letters and dangerous abbreviations should be banned. A prescription is like a medical command. It must be precise.
Standardized.
Yes, standardized medication orders are crucial. Hospitals should use a uniform, approved format for all medication orders, whether electronic or paper. This includes mandatory fields like patient name, drug name, dose, route, frequency, and duration. No shortcuts allowed. Standardization prevents fatal misunderstandings caused by ambiguity.
Okay, so it's prescribed safely. What about getting it from the pharmacy?
That's safe dispensing. The pharmacy acts as a crucial checkpoint. Pharmacists must check every detail of the prescription against the medication dispensed rate, drug, strength, expiry date, patient name. They need systems to recall faulty batches of medication if needed, and track returns or wastage, especially for controlled drugs. Dispensing is a vital defense layer before the drug reaches the patient's bedside.
And finally, giving the medication.
Safe administration. This is where the 5 rights we talked about earlier are absolutely critical. Right patient, right drug, right dose, right route, right time. Nurses perform these checks meticulously. Barcode scanning at the bedside is increasingly used for an extra layer of safety. They also need to prevent errors like misconnecting IV lines, and everything, the checks, the administration time must be documented immediately. Precision in every single dose.
But it doesn't end there, does it?
No, monitoring after medication is a crucial safety net. Patients must be monitored for the intended effects, but also for side effects or adverse reactions. Staff need to track vital signs or specific parameters, like blood sugar after insulin. Importantly, there needs to be a system for capturing and reporting any medication errors, adverse drug reactions, ADRs, or even near misses. Analyzing this data helps prevent future errors. Administration isn't the end, observation is key.
What about particularly dangerous drugs?
There are specific standards for handling high-risk medications. Narcotics, chemotherapy agents, radiopharmaceuticals, these require strict handling protocols. Think locked storage, access restricted to specifically trained staff only, detailed usage logs tracking every dose. High-risk drugs demand high-level responsibility.
And this extends beyond just drugs, right, to implants and supplies?
Yes. Implantable devices like pacemakers, artificial joints must also be managed safely. Only approved devices should be used, patients and families need full counseling, and serial numbers or batch numbers must be meticulously documented in the patient's record for traceability. Medical implants aren't plug and play. They are regulated tools requiring careful management.
Okay.
And even basic medical supplies and consumables, gloves, syringes, dressings need proper management. They must be stored cleanly and securely, inventory tracked, expiry dates checked regularly, and disposed of safely. Even the smallest item can impact patient safety if it's expired or contaminated.
It's incredibly thorough. Let's see how this all played out in the example of Mr. Remish's case from the guide.
Right. Mr. Ramesh is admitted with chest pain. The pharmacy immediately consults the hospital's approved formulary to guide the selection of his heart medications. His insulin, a high-alert drug, is stored in a dedicated, temperature-monitored fridge in the ward's medication room, storage. Emergency trolleys on the ward are checked daily to ensure cardiac arrest medications are present and within expiry date. The cardiologist carefully checks Mr. Ramesh's allergy history in the EHR before ordering a new blood pressure medication. The prescription is entered digitally, clearly specifying dose, route, and frequency prescribing. In the pharmacy, the pharmacist double-checks the digital order against the medication label, verifying the drug name, strength, and Mr. Ramesh's name before dispensing it in a labeled container. Dispensing.
Multiple checks.
Yes. At the bedside, the nurse uses a handheld scanner to scan Mr. Ramesh's wristband and then the medication barcode. The system confirms it's the right patient, drug, dose, route, and time the 5 rights before she gives the pill administration.
Technology helping there.
Definitely. A little later, Mr. Ramesh feels dizzy. The nurse checks his blood pressure, finds it low, documents it, and immediately informs the doctor. This is diligent monitoring after medication. The doctor adjusts the dose.
Quick response.
At discharge, the pharmacist reviews all the medications Mr. Ramesh was taking before admission and compares them with the new discharge prescriptions, resolving any discrepancies. This is medication reconciliation. And if, say, he received a cardiac stent, an implantable device, during his stay, its type and serial number would be clearly documented in his discharge summary for future reference.
Oh.
That entire sequence, really shows how MOM standards create this continuous interconnected chain of safety checks, safeguarding the patient at every single step of the medication process.
Exactly. It's about building multiple layers of defense against potential errors.
That was a fantastic deep dive into medication safety. Now let's pivot to something equally critical, especially in hospitals: infection prevention and control, or IPC. Our guide uses another powerful analogy here.
Yes, it does. It says, imagine a hospital as a clean kitchen serving healing recipes. One drop of infection in the system can ruin it all.
That's potent. A clean kitchen. It perfectly illustrates the potentially devastating impact of hospital-acquired infections, or HAIs. These infections aren't just complications. They increase patient suffering enormously, they escalate healthcare costs significantly, and they prolong hospital stays, sometimes tragically.
And the guide emphasizes it's everyone's job.
Absolutely. The guide stresses that IPC isn't just the responsibility of an infection control nurse, it's everyone's job. From the CEO to the cleaning staff, every single person has a role to play. Clean hands, sterile techniques, clean environment, these practices, when done consistently by everyone, save lives every single day.
So the fundamental truth is,
great IPC keeps hospitals as places of healing, not places where patients pick up new harms.
So how do hospitals organize themselves to effectively fight these infections? It sounds like it needs a dedicated, structured effort.
It absolutely does. It can't be haphazard. It starts with having a formal, structured IPC program. This means the hospital must have an organized infection control program, usually overseen by a dedicated infection control committee, ICC.
Oh.
Yes, and often supported by a full-time infection control team, or ICT, comprising trained professionals like doctors or nurses specializing in infection control. They develop policies, conduct regular audits, provide training, and analyze surveillance data. And crucially, this program needs visible support and approval from senior hospital leadership.
So leadership buy-in is key.
Essential. Prevention isn't just luck. It's the result of strong leadership, careful planning, dedicated resources, and a visible structure driving it.
Okay, so they have a program.
Yeah.
But how do they know if it's working? How do they track if infections are actually happening or spreading? That sounds like a massive tracking job.
It is, and it's called infection surveillance. This is a core function of the IPC program. It requires the hospital to actively, systematically track infection trends. They need to know who's getting infected, where in the hospital infections are occurring, example, ICUs, surgical wards, when, and ideally, why?
What kinds of infections do they track?
Typically, they focus on common and high-impact HAIs, like surgical site infections, SSIs, catheter-associated urinary tract infections, CADIs, ventilator-associated pneumonia, VAP, and central line-associated bloodstream infections, CLAB-SIs.
Okay.
They use standardized definitions and reporting tools, like incidence logs, to collect this data. And crucially, they don't just collect it, they analyze it. They look for trends, outbreaks, and they often benchmark their infection rates against national or international data.
To see how they compare.
Exactly. It helps them identify areas where they need to improve. The key takeaway here is fundamental. What you don't track, you can't fix. Without surveillance data, prevention efforts are essentially flying blind.
So based on that data and general risks, how do they actually reduce the chances of infection spreading, especially in those high-risk areas like operating rooms or ICUs?
This involves two key sets of practices: reducing HAI risks in specific areas and implementing universal safety measures known as standard precautions.
Let's start with reducing risks in specific areas.
All high-risk areas, ORs, ICUs, maybe dialysis units, must follow specific infection control protocols tailored to their environment. This could include things like specialized ventilation systems in operating rooms, strict protocols for inserting and caring for invasive devices like central lines or urinary catheters, often called device care bundles, and having dedicated isolation rooms with specific air pressure controls for highly infectious diseases. The goal is to break potential chains of infection before they start, especially where patients are most vulnerable.
Okay, and what about these standard precautions?
Standard precautions are the absolute foundation of IPC. They are universal safety steps that healthcare workers must follow for all patients all the time, regardless of whether the patient has a known infection or not.
Why for everyone?
Because you might not know who has an infection, and some infections can be spread before symptoms appear. So you treat every patient interaction as potentially infectious.
What does that involve practically?
It includes consistent hand hygiene washing or gelling hands before and after touching a patient or their surroundings. Using personal protective equipment, PPE, like gloves, masks, eye protection, or aprons when anticipating contact with blood, body fluids, or potentially contaminated surfaces. Ensuring equipment used for patient care is properly cleaned and disinfected between patients. And strictly prohibiting the reuse of single-use disposable items.
Treat everyone safely.
Exactly. Assume everyone could potentially transmit something, and act accordingly to protect yourself and other patients.
What if you know a patient has a specific infectious disease? Are there extra steps then?
Yes, that's where transmission-based precautions come in. These are additional layers of protection used in addition to standard precautions for patients with known or suspected infections that spread in specific ways.
Like what?
For airborne diseases like tuberculosis or measles, this might involve placing the patient in a negative pressure isolation room and staff wearing high filtration N95 masks. For diseases spread by droplets, like flu, it might mean wearing a surgical mask when close to the patient. For contact spread infections, like MRSA or C. difficile, it involves wearing gowns and gloves for all contact with the patient or their environment. Clear signboards are usually placed on the patient's door to alert staff about which precautions are needed. The goal is to stop that specific mode of transmission at the door.
Okay, that makes sense. What about hospital waste? That seems like another major source of potential infection.
Absolutely. Proper biomedical waste management is critical. All waste generated during diagnosis, treatment, or research used sharps, contaminated dressings, lab samples must be handled, segregated, stored, and disposed of safely according to strict regulations.
How's that done?
Typically using a system of color-coded bins for different types of waste. For example, yellow for infectious waste, red for contaminated plastics, blue for sharps. Sharps must go into puncture-proof containers immediately. Hospitals usually contract with certified waste management vendors who collect and treat this waste appropriately, for example, incineration, autoclaving. Clean disposal isn't just about tidiness, it's a critical public health and environmental safety measure.
And you mentioned hand hygiene as part of standard precautions, but it seems so important it probably gets extra focus.
It does. Hand hygiene compliance is relentlessly emphasized in NABH standards because it's arguably the single most effective way to prevent HAIs. Hospitals prominently display reminders, often using the World Health Organization's 5 moments for hand hygiene model.
The 5 moments?
Yes, before touching a patient, before clean aseptic procedure, after body fluid exposure risk, after touching a patient, and after touching patient surroundings. Alcohol-based hand rubs must be readily available everywhere, at bedsides, entrances, hallways, and compliance isn't just encouraged, it's monitored. Often through direct observation or secret shopper-style audits, where trained observers watch staff during routine care and record whether they perform hand hygiene at the key moments. Compliance rates are tracked and fed back to departments. The simple truth remains. Soap and alcohol rub are the cheapest yet strongest medicines we have against infection spread.
And all staff need to know this stuff inside out.
Yes, training and compliance are essential. All hospital staff, from doctors to support staff, must receive comprehensive training on IPC principles and practices during their induction, and then regular annual refreshers. This often includes practical demonstrations, like how to properly put on and take off PPE. Compliance with policies is monitored, and retraining is provided where needed. Practice doesn't just make perfect. In infection control, consistent practice prevents harm.
Let's look at the real-world example from the guide, the neonatal ICU and NICC drill. How does that illustrate these standards?
This NICU drill is a fantastic example of IPC in action. The infection control nurse proactively plans a drill simulating a suspected MRSA case that's part of the IPC program and risk preparedness.
Okay.
When the case is identified, all staff immediately drum out appropriate PPE, gowns, gloves, and place the baby mannequin in isolation, demonstrating both standard and transmission-based precautions. Swabs are taken from the mannequin and sent to the lab for culture, which mimics the process feeding into infection surveillance. Communication is key. Signboards detailing the required precautions are placed on the isolette, and handover logs ensure the next shift is fully aware. After the patient is discharged, environmental services perform terminal cleaning of the space according to protocol, which is crucial for reducing HAI risks for the next occupant.
And the outcome?
The drill debrief confirms no breaches and protocol occurred, simulating a scenario where infection spread was successfully prevented. This highlights how rigorous training and coordinated team response, guided by clear IPC standards, can effectively contain outbreaks even in the most high-risk, vulnerable settings like a NICU. It ultimately ensures safe healing for the tiniest patients.
That's a powerful illustration. Okay, we've talked extensively about the systems, the patient journey itself, and those critical safety elements like medications and infection control. Now let's talk more about the human element, starting with how hospitals ensure patient rights and education, PRE.
Right. This chapter is really about the patient experience from a dignity and empowerment perspective. The guide offers another beautiful analogy here. Think of a hospital like a bridge between illness and health. Patients must feel respected, understood, and empowered to cross it.
Respected, understood, empowered. I like that.
It perfectly captures the essence. This section is about ensuring that patients' fundamental rights are protected throughout their stay, that they understand their responsibilities in their own care, and that effective education helps them take control of their condition and recovery. Great PRE fundamentally builds trust. And as the guide notes, a confident, informed patient is often a more compliant and engaged patient.
So how do hospitals proactively protecting rights? What does that look like in practice, ensuring privacy, safety, dignity?
Hospitals are required to actively protect these core patient rights at all times. In practice, this translates into concrete actions. For privacy, it means ensuring no unauthorized people are present during examinations or discussions, using curtains or screens effectively between beds and shared rooms. For safety and dignity, it includes things like offering lockers for personal belongings, implementing robust security protocols, especially for vulnerable groups like children, the elderly, or psychiatric patients. Respect and safety aren't optional extras in healthcare. They are absolute essentials, woven into the very fabric of care delivery.
And patients need to know these rights exist.
Absolutely. Which leads to the next standard, informing patients. Patients must be clearly told about their rights and their responsibilities upon entry into the hospital.
Oh.
Again, using multiple methods, clear posters or pamphlets, often in local languages, verbal explanations from staff during admission. Some hospitals might even have information available in Braille or audio formats for visually impaired patients. Clear signboards reinforcing key rights like confidentiality might also be used. The principle is, if rights aren't known, they can't be exercised effectively.
Makes sense. And when it comes to making actual decisions about their treatment, how do hospitals ensure patients are truly making informed decision-making? We touched on consent earlier, but this seems broader.
It builds on informed consent. This standard ensures patients receive enough clear, understandable information to genuinely make their own choices about their care pathway. This means healthcare providers must explain not just the procedure, but the risks, the expected benefits, and the reasonable alternatives, including the option of no treatment.
It's a simple language.
Yes, using simple, non-technical language is crucial. Avoiding jargon. Allowing ample time for questions. Ensuring the patient comprehends the information before they consent. The guiding principle, again, is that powerful phrase, no decision about me without me. It puts the patient firmly in the driver's seat regarding their own health journey.
Okay, what about education for life after the hospital? Ensuring the healing continues effectively at home.
That's where health education comes in. This standard focuses on equipping patients, and often their families or caregivers, with the knowledge and skills needed for ongoing recovery and self-management.
What kind of education?
It can cover understanding their specific condition, the purpose of their medications, necessary lifestyle changes like diet or exercise, how to manage wounds or use medical devices at home. It often involves using visual aids, simple written materials, and that teach-back method we discussed to confirm understanding. Educating family members is often key, especially for patients needing significant home care. Sometimes, providing helpline numbers or contacts for patient support groups is also part of this. The goal is to empower the patient because healing continues long after discharge.
And finally, a really important aspect. How do hospitals show respect for beliefs and values, recognizing that patients are whole people with cultural and spiritual needs?
This is a crucial element, acknowledging that healthcare needs to be holistic. The standard requires hospitals to make reasonable efforts to honor patients' personal, cultural, spiritual, and religious beliefs, as long as they don't compromise safety or essential care.
What might that look like?
It can manifest in various ways, offering dietary options that meet religious or personal needs, like vegetarian or halal meals, providing access to prayer rooms or facilitating visits from spiritual counselors or clergy if requested, ensuring gender-sensitive care, for example, having female staff available for examinations or care if a female patient prefers, respecting decisions regarding specific treatments like blood transfusions based on deeply held religious beliefs, while ensuring the patient understands the risks. It's about recognizing that healing involves the heart and spirit, not just the physical body.
Let's use the real-world example from the guide, Mrs. Aisha's Delivery, to illustrate how these PRE standards come together in practice.
Mrs. Aisha's experience is a great example. Upon admission for delivery, she sees posters in Urdu explaining patient rights and the consent process that's informing patients. Staff also verbally explain what to expect during labor. During examinations, curtains are always drawn, ensuring her privacy, a key right. As per her request, only female staff attend to her personal care needs, demonstrating respect for her beliefs and values and ensuring her dignity.
Good.
When the possibility of a C-section arises, the doctor sits down with Mrs. Aisha and her husband, clearly explaining the risks and benefits compared to continuing labor. They answer all their questions before they find the consent form that's informed decision-making in action.
Clear communication.
Before discharge, the nurses teach Mrs. Aisha how to breastfeed effectively and how to spot signs of infection in herself or the baby. They use diagrams and give her a printed guide in Urdu, excellent health education. Her request for a female-only recovery room is honored, and the hospital facilitates a visit from an imam for prayer when requested, further showing respect for beliefs and values and protecting her rights.
So this whole scenario highlights how these PRE standards aren't separate checklist items, but are woven into the entire fabric of care, creating a respectful, empowering, and culturally sensitive environment for the patient.
Exactly. It makes a huge difference to the patient's overall experience and trust.
That was a powerful look at the patient's perspective on rights and education. Now, let's shift our focus slightly to the other side of the equation. The people who deliver all this care. Let's talk about human resource management, HRM.
Right, because the quality of care is inextricably linked to the people providing it. The guide puts it very well. A hospital can only function as well as its people. From doctors to cleaning staff, every person matters.
Everyone matters.
It emphasizes that having the right people with the right skills and training directly equates to quality patient care. Furthermore, how those staff are managed their training, motivation, safety, and fair treatment impacts performance, consistency, staff retention, and overall morale. Strong HRM is absolutely fundamental to building and sustaining a strong, positive hospital culture.
So how do hospitals ensure they actually have enough qualified staff to meet patient needs? And how do they bring new hires on board effectively?
It starts right at the beginning with meticulous HR planning. Hospitals can't just hire randomly. They must systematically plan their human resource needs based on the types of services they offer and their anticipated patient volumes or acuity levels. This often involves setting staffing norms or ratios for different units, creating an annual HR budget, and even forecasting workforce needs for peak times or potential expansions. Good planning prevents chronic understaffing, burnout, and service gaps.
Okay, planning first, then recruitment.
Yes, recruitment and induction. Hiring processes must be fair, transparent, and well documented. This includes things like verifying credentials and backgrounds thoroughly, using clear job descriptions that outline required qualifications and responsibilities. And once hired, a structured induction or orientation program is crucial.
What should induction cover?
It's not just paperwork. It needs to cover critical aspects like the hospital's mission and values, key safety protocols like fire safety, infection control, patient rights, ethical guidelines, and how to use essential hospital systems. A professional onboarding process sets the stage for a positive and productive employment journey right from day one.
Okay, so they've hired people and onboarded them. Beyond that initial phase, how do hospitals ensure their staff remain competent and continuously develop their skills? Healthcare changes so fast.
That's a key challenge and a critical standard. It involves ongoing staff qualification and competency validation, plus continuous training and skill development.
Qualification and competency first.
Yes. Every staff member must possess valid current credentials for their role, like a valid registration or license for nurses and doctors. But it goes beyond just paper qualifications. Hospitals need processes to assess and ensure actual competency. Can the nurse correctly operate the ventilator? Can the technician perform the lab test accurately? This might involve skill testing during probation, periodic competency assessments for specific procedures, or maintaining a competency matrix for different roles. Qualified doesn't just mean having a degree, it means being demonstrably capable of doing the job safely and effectively.
And the continuous learning part.
Because healthcare is always evolving, hospitals must provide opportunities for training and skill development. This isn't an optional extra, it's essential. It includes things like regular continuing medical education, CME sessions for doctors, mandatory training in basic life support, BLS, and often advanced cardiac life support, ACLS, for clinical staff. workshops on new techniques or technologies, infection control refreshers, and even simulation drills for emergency scenarios. Attendance and participation in training should be tracked.
Yeah. Investing in their people.
Exactly. Training isn't an expense. It's an investment in quality and safety.
And what about the staff's own well-being and development? How do hospitals make sure staff are safe, their rights are protected, and they get feedback on how they're doing?
These are covered under Staff Safety and Rights and Performance Review. Just as hospitals must protect patients, they must also protect their staff from harm. This includes providing appropriate PPE, offering necessary vaccinations like hepatitis B, having robust policies against workplace violence or harassment, and ensuring a safe physical environment. Staff also have rights like fair working hours, access to a grievance redressal mechanism if they have concerns, and protection from discrimination. A safe and respected staff provides safer care.
And performance feedback.
Regular performance review is vital for growth and accountability. All staff members should be evaluated periodically, usually annually, against clear expectations and performance standards, often linked to KPIs. They should receive constructive feedback on their strengths and areas for development, covering aspects like clinical skills, teamwork, communication, and adherence to policies. Promotions, salary increments, or identifying further training needs are often linked to these performance reviews. Good feedback fuels professional growth.
Finally, how is all this employee information managed?
Through systematic personnel file management. Hospitals must maintain secure, accurate, and up-to-date records for every employee. This includes their resume, ID proofs, copies of certificates and licenses, training records, performance appraisals, etc. These files, whether physical or digital, must be kept confidential with access restricted to authorized HR personnel. Maintaining organized files is essential for managing the workforce effectively and ensuring compliance.
Let's apply this to the real-world scenario from our guide, the specialty hospital example. How does it demonstrate these HRM standards?
This hospital provides a good illustration. They conduct a yearly workforce analysis based on projected patient numbers, which informs their HR planning, like deciding to expand the ICU nursing team next year.
Proactive planning.
Yes. All new hires, regardless of position, go through a standardized 3-day induction program covering hospital policies, safety, and patient rights, demonstrating good recruitment and induction.
Okay.
For staff qualification and competency, their ICU nurses aren't just hired. They undergo specific training and are then validated on handling ventilators every 6 months. Doctors participate in a 360-degree feedback process for their performance review, getting input from peers and nurses, not just superiors.
Comprehensive feedback.
For staff safety, housekeeping staff are consistently provided with appropriate PPE, gloves, boots, and receive specific training on handling spills safely. The OPD team has monthly training sessions focused specifically on improving patient communication skills. And all employee records, licenses, training certificates, appraisals are managed securely via an encrypted HR software system, ensuring effective personnel file management.
So it's an integrated approach: planning, hiring, training, evaluating, protecting, and managing records, all working together.
Exactly. This integrated approach builds a strong, capable, safe, and hopefully motivated hospital workforce, which is ultimately fueled by and for its people.
Okay, we've covered a tremendous amount of ground on the operational aspects: patient flow, care delivery, meds, infections, and the people delivering that care. Now let's move into part 5, which focuses on the foundational pillars: hospital management, the physical facilities, and information systems. Let's start with the responsibility of management.
Right. This chapter is crucial because leadership sets the tone for everything else. The guide uses that great analogy again. If a hospital were a ship, management is the captain.
The captain of the ship. Makes sense.
It emphasizes that no matter how skilled the individual crew members are, the doctors, nurses, etc., clear direction, resource allocation, and overall smooth sailing depend heavily on the captain, on the bridge crew, the management team.
So what are their key responsibilities?
It boils down to a few core areas. Management must actively drive the leadership for quality and safety culture. They need to ensure legal and regulatory compliance. They're responsible for effective communication and adequate resource allocation. They must champion and enforce ethical practices. And finally, they need robust systems for performance monitoring and improvement. Good governance, essentially, creates the environment for great care.
Let's break those down. What does it mean for management to truly lead for quality and safety and ensure the hospital stays on the right side of the law?
Leadership for quality and safety means it can't be delegated entirely to a quality department. Top management, the CEO, the medical director, the board, must be visibly and actively involved. This means they should ideally chair the hospital's quality and safety committee. They need to define and communicate a clear vision and policies for quality, and they must personally review data on safety events, infection rates, patient feedback, and drive improvement initiatives. Leadership isn't passive. It actively sets the tone and priorities for the entire organization. Safety and quality start at the top.
And the legal side.
Legal and regulatory compliance is non-negotiable. Hospitals operate in a highly regulated environment. Management is responsible for ensuring the hospital complies with all applicable laws and regulations. This includes obtaining and maintaining all necessary licenses like the fire NOC, no obstruction certificate, permissions for biomedical waste disposal, registration under the Clinical Establishment Act. It also covers labor laws, specific regulations for services like radiology, AERB rules, or ultrasound, PCP and DT Act. Regular internal or external audits are needed to ensure ongoing compliance. A legally compliant hospital is fundamentally a trustworthy hospital.
Okay, so leadership and legality are set. How does management ensure the hospital actually runs smoothly day to day? Thinking about communication, resources, and ethics.
These are critical operational responsibilities. Effective communication is paramount. We know communication failures are a leading cause of medical errors. So management must ensure clear and effective communication channels exist across all departments and levels of staff. This could involve daily team briefings, monthly interdepartmental meetings, using notice boards effectively, having internal communication systems like email or secure messaging apps, and crucially, having mechanisms for staff to provide feedback upwards.
Two-way communication.
Exactly. Then there's resource allocation. Intentions are great, but without resources, quality care is impossible. Management is responsible for ensuring the hospital has enough resources. That means adequate numbers of trained staff, like maintaining appropriate nurse-to-patient ratios, especially in critical areas, sufficient equipment that's functional and available, adequate supplies, including monitoring emergency stocks, and robust technology systems like EMRs, billing systems, or picture archiving systems, PITS for radiology.
Matching resources to needs.
Precisely. And finally, ethical practices. Management must actively promote and rigorously enforce ethical conduct throughout the hospital. This often involves establishing an ethics committee to handle complex cases or research proposals. It means having clear policies with zero tolerance for unethical behaviors like bribery, fraud, or discrimination. And it requires transparency in areas like patient billing and the informed consent process. Ethics must be actively practiced and enforced, not just mentioned in a policy document.
And how does management keep track of how the hospital is doing overall and make sure it's continuously improving?
That comes down to performance monitoring. Management can't just set things up and walk away. They must continuously monitor the hospital's overall performance across key areas and take corrective action when needed. This involves defining and tracking relevant key performance indicators.
KPIs.
KPIs, again, like what? Things like overall hospital occupancy rates, average length of patient stay, patient satisfaction scores, staff satisfaction scores, key clinical outcome measures, readmission rates, financial performance. Management should hold regular review meetings, maybe quarterly, to discuss these metrics, analyze trends, and develop action plans to address areas that are underperforming. The principle holds: what gets measured gets managed and hopefully improved.
Our guy gives us the example of Heights Hospital again. How does their management demonstrate these responsibilities?
Heights Hospital provides a good picture. Their CEO personally chairs the monthly quality and safety meetings, demonstrating active leadership for quality and safety. All their legal registrations and license renewals are tracked digitally with automated alerts, ensuring ongoing legal and regulatory compliance. They use an internal mobile app to share policy updates and patient safety alerts instantly with all staff, showcasing effective communication. When performance monitoring data showed a persistent shortage of nurses in the ICU impacting care, management approved and initiated new recruitment within 10 days, demonstrating responsive resource allocation. After an internal audit flagged an issue where consent wasn't properly documented in one department, immediate retraining was conducted and the process corrected, reinforcing ethical practices around consent. And finally, patient feedback consistently highlighted long waiting times in the outpatient department. Management analyzed the process, identified bottlenecks, and implemented a complete overhaul of the appointment and queue management system, resulting in reduced wait times. This shows active performance monitoring leading to tangible improvements. It's a hospital where management appears truly engaged and responsive.
That's a great illustration of management's role. Now let's move on to the physical environment itself. Facility management and safety, FMS. Our guide calls these the invisible protectors.
And that's a very apt description, because a hospital's safety doesn't just depend on the skills of the doctors and nurses. It equally relies on things we often don't think about unless they fail: reliable power systems, clean water, efficient plumbing and sewage disposal, properly maintained medical gas pipelines, clearly marked and unobstructed fire exits, functional elevators.
The infrastructure.
Exactly. Safe facilities protect everyone inside: patients, staff, and visitors. Good facility management means fewer disruptions to care, like a power outage during surgery, and a more efficient environment. And crucially, robust emergency preparedness can literally save lives in seconds during a fire or other disaster. Great patient care fundamentally starts with a safe, secure, and functional physical environment.
So how do hospitals plan for and maintain such a complex physical infrastructure, ensuring it's always safe and also accessible to everyone?
It starts with having a comprehensive, documented facility management program. The hospital must have a clear plan, usually overseen by a dedicated facility management team or engineer. This plan covers everything from routine preventive maintenance schedules for all critical equipment to procedures for handling unexpected breakdowns, managing pest control, and conducting regular safety audits of the premises. This plan needs to be reviewed and updated regularly.
And making sure it's accessible.
Yes. The standard for safe, accessible facilities requires that the buildings themselves are kept clean, safe from hazards like slippery floors or obstructions, and are easily accessible to all patients, including those with disabilities. This means things like having ramps in addition to stairs, clear directional signage throughout the hospital, accessible restrooms, and functional lifts designed to accommodate wheelchairs or stretchers. Every patient deserves to receive care in a clean, safe, and easily navigable space.
Okay. What about preparing for the unexpected? Fires, earthquakes, other disasters. How do hospitals get ready for emergencies?
This is absolutely vital: emergency preparedness. Hospitals must be prepared to respond effectively to various potential emergencies. Fire is the most common focus, but it could also include things like major power failures, internal floods, gas leaks, or even external disasters like earthquakes or mass casualty incidents.
What does preparation involve?
It involves having the right equipment in place and ensuring it works: things like fire extinguishers, smoke detectors, alarm systems, sprinkler systems, and testing them regularly, for example, monthly. It means having clear evacuation plans with designated escape routes and assembly points clearly marked on floor plans displayed throughout the hospital. And crucially, it means training all staff through regular drills on what to do in each type of emergency, how to use an extinguisher, how to evacuate patients safely, especially those who are non-ambulatory. In a crisis, panic is the enemy. Thorough preparation and practice save lives.
Definitely. And beyond major emergencies, what about the basic utilities we rely on every second? Power, water, medical gases, and managing hazardous materials.
Utility management is critical for uninterrupted care. Hospitals must ensure their essential utility systems, electrical power, water supply, medical gases like oxygen, vacuum, and ventilation systems, HVAC, function reliably 24/7. This means having adequate backup systems, especially for critical areas like ICUs and ORs, typically powerful generators that kick in automatically during a power outage. It involves regular testing of water quality to ensure it's safe, and maintaining medical gas pipelines with functional alarms and monitoring systems. Uninterrupted utilities are absolutely non-negotiable for patient safety.
And hazardous materials.
Safe hazardous material handling is also key. Hospitals use many potentially hazardous substances, chemicals in the lab, cleaning agents, chemotherapy drugs, radioactive materials, and of course, infectious waste. They need clear protocols for safely storing, handling, using, and disposing of all these materials. This includes having material safety data sheets, MSDS, readily available for all chemicals, ensuring sharps are disposed of immediately into puncture-proof boxes, and having spill kits and appropriate PPE available for staff who handle these materials. When hazards are managed correctly, they don't pose a threat to patients or staff.
What about the long-term safety of the building structure itself and all the complex equipment inside it?
This falls under building and equipment safety. The hospital's physical infrastructure, the walls, floors, ceilings, electrical wiring, plumbing needs to be sound and regularly inspected for integrity. Critical equipment like elevators, boilers, large sterilizers, autoclaves, HVAC systems requires regular preventive maintenance, often through annual maintenance contracts, AMCs, with specialized vendors. Detailed maintenance logs must be kept for all critical equipment. A well-maintained hospital is fundamentally a safer hospital.
And many hospitals are looking at sustainability now, too.
Yes, increasingly, environmental sustainability is becoming part of FMS. Hospitals are often large consumers of energy and water and generate significant waste. Many accredited hospitals are now actively implementing eco-friendly practices, installing solar panels, using energy-efficient LED lighting, implementing water recycling systems, reducing plastic use, like becoming plastic-free zones, and even incorporating green landscaping. A healthy planet supports healthy people, and hospitals are recognizing their role in this.
Our guide gives a compelling example of Green Care Hospital safety turnaround. Can you walk us through that?
Green Care Hospital's story is a great illustration of FMS improvement. They faced a significant setback. Their routine fire safety inspection failed due to outdated alarm systems and, worryingly, the absence of a documented evacuation plan. This was a major red flag.
Definitely.
Management took this very seriously. They immediately formed a task force, developed a detailed fire safety standard operating procedure, SOP, and conducted intensive training for all departments on fire response and evacuation roles. They invested in a significant facility upgrade, installing modern fire alarms with visual indicators, LED lights for noisy areas, and put up clear phosphorescent evacuation route signage. They then conducted mock drills involving staff, even simulated patient evacuations.
So they addressed the failures directly.
Head on. As a result, they passed the re-inspection with flying colors. But they didn't stop there. Showing a commitment to broader safety and sustainability, they also introduced solar power backup for essential lighting and critical medical equipment, reducing reliance on generators during outages. This focus on comprehensive facility management and safety not only ensured compliance, but also led to them achieving a Green Hospital certification. It really showcases how a serious commitment to FMS can create a safer, more resilient, and even more sustainable healthcare environment.
That's a fantastic turnaround story. Okay, that covers the physical foundations. Now let's move to the final pillar in this section, how all the critical information within the hospital is managed. The guide calls the Information Management System, IMS, the hospital's nervous system.
That's precisely the analogy used, and it's perfect. Think of the Information Management System, or IMS, as the hospital's nervous system. Just like the brain uses nerves to send messages throughout the body, IMS uses records, reports, and software systems to keep information flowing smoothly, enabling coordinated care.
The nervous system. Okay.
It highlights that reliable, accurate data leads to better clinical and managerial decisions. Maintaining confidential data is crucial for building and keeping patient trust, and ensuring timely, appropriate access to that data is essential for smooth coordination between different caregivers and departments. A good IMS, therefore, needs to be accurate, secure, and accessible, but only at the right time and only to the right authorized person.
So how do hospitals ensure all this vast amount of information, whether it's still on paper in some places or fully digital, is organized, accurate, complete, and kept confidential?
It starts with having an effective information system in place. This doesn't just mean having computers. It requires a structured, secure system for managing all types of clinical and administrative information. Whether using electronic health records, EHRs, or well-organized paper files, there need to be controls like version control for documents, standardized formats for notes and reports, and clear standard operating procedures, SOPs, covering data entry standards, access permissions, and how edits or corrections are handled. The goal is to ensure information is organized, consistent, and reliable, not chaotic or fragmented.
And the patient records themselves.
Ensuring complete, confidential patient records is paramount. Each patient's record, whether physical or digital, must be comprehensive, containing all relevant information. Medical history, diagnosis, treatment plans, investigation results, consent forms, progress notes, nursing records, discharge summary, even billing information ideally linked in one place. And critically, these records must be protected from unauthorized access or disclosure.
How is confidentiality maintained?
Through various measures. Strong password protection and role-based access controls for digital EHRs. Secure storage like locked cabinets or record rooms for physical files, clear policies and staff training on patient privacy and confidentiality, often linked to IPA in the US or similar regulations elsewhere. Incomplete or insecure records can lead to incomplete care or breaches of trust.
Okay, so the data is stored securely and completely. But information isn't useful if the people who need it can't get it when they need it. How do hospitals ensure timely access while maintaining security?
That's the critical balance. Timely access for authorized users versus data security and backup. Doctors, nurses, pharmacists, therapists, they need to be able to access the right patient information quickly to make timely care decisions. This requires efficient systems, maybe role-based logins that grant access only to relevant parts of the record, emergency access protocols for critical situations with audit trails, and having sufficient computer terminals or secure mobile access points available on wards for easy access. Information delayed can absolutely lead to care being delayed, sometimes critically.
But that access needs to be secure.
Absolutely. Robust data security and backup measures are non-negotiable. All data, especially sensitive patient information, must be rigorously protected from loss due to system failure or disaster, damage, corruption, or unauthorized use, hacking, internal snooping. This involves technical safeguards like regular automated IT backups stored securely off-site, strong antivirus software and firewalls, data encryption, both when stored and transmitted, and physical security for servers. A comprehensive disaster recovery plan is essential. What happens if the main system goes down? One significant data breach or loss of records can cost lives, destroy trust, and lead to massive legal and financial repercussions.
And hospitals often use both paper and digital systems, right? How is that managed?
Yes, many hospitals are in transition or use hybrid systems. The standard for managing both paper and digital records emphasizes that both systems must adhere to the same high standards of quality, security, confidentiality, and accessibility. This might mean using uniform formats for handwritten notes to ensure legibility, implementing barcode tracking systems for physical files to know where they are, and ensuring robust backup procedures exist for both digital data and a plan for accessing critical information if the digital system fails. Whether it's paper or pixels, the information must be safe, complete, accurate, and readily retrievable when needed.
Beyond just storing all this data, how do hospitals actually use it to improve things?
Data isn't just for storage or billing, it's a powerful tool for improvement. The standard on using data for improvement requires hospitals to actively utilize the information they collect for enhancing quality of care, supporting clinical research where appropriate and ethical, and monitoring patient outcomes.
How does that happen?
Through processes like regular morbidity and mortality review meetings where clinical data is analyzed to learn from adverse outcomes. Analyzing patient feedback, complaints, and incident reports to identify recurring problems or trends, using anonymized clinical data for internal quality audits, benchmarking exercises, or even approved research studies. The goal is to transform raw data into actionable insights that drive smarter decisions and continuous improvement across all hospital functions. Data needs to fuel action.
And staff need to know how to use these systems properly.
Yes, staff training on IMS is crucial. All staff who interact with the information system, doctors, nurses, clerks, technicians, must be trained on how to use it correctly, efficiently, and responsibly. This includes understanding login procedures and password policies, how to navigate the EHR or file system, the importance of accurate and timely data entry, strict adherence to confidentiality rules, and maybe even participating in mock drills for retrieving records during downtime. A trained user is fundamentally a safer and more effective user of the information system.
The guide provides a fantastic example of Aroja Hospital's digital upgrade. Can you describe that?
Aroja Hospital's story really highlights the impact of a good IMS. They were facing a common, frustrating problem, constantly losing paper OPD slips, leading to chaotic follow-up appointments and delays. This was an information system failure.
Right.
They addressed this head-on by implementing a comprehensive hospital information system, HIS. A key feature was barcode tracking for all patient files, both inpatient and outpatient, which dramatically improved their ability to manage both paper and digital records effectively. Lost files became rare.
Big improvement.
To enhance data security, especially for sensitive ICU records, they implemented biometric fingerprint login for accessing the ICU module of the HIS. They also shifted their data backup strategy to a more robust cloud-based system with end-to-end encryption. The results were remarkable. They reported a 60% drop in documentation errors within 6 months, likely due to standardized digital formats and reduced lost information. Patient wait times in the OPD also reduced significantly because files and previous records were instantly accessible electronically. This clearly shows how they use data, the problem of lost slips and delays, to drive an effective information system upgrade, which in turn led to tangible quality improvements in patient care and efficiency. It's a powerful case study on the value of investing in and managing information well.
Absolutely. Okay, we've journeyed through the entire hospital ecosystem, from the patient walking in, the care they receive, the critical safety nets like meds and infection control, the people involved, the management oversight, the physical facility, and the information systems. Now let's wrap things up in part 6 by focusing on the overarching goals. Patient safety and quality improvement, PSQ, which acts as a powerful capstone to everything we've discussed.
Yes, exactly. PSQ isn't just another chapter, it's really the culmination, the ultimate goal of all the other standards working together. The guide beautifully frames the core purpose. A hospital is not just a place to treat illness, it's a place to heal safely and improve constantly.
Heal safely and improve constantly. I like that focus.
It breaks down like this. Safety means actively working to avoid preventable harm to patients during their care. Quality means consistently doing the right thing, in the right way, at the right time, for the right patient to achieve the best possible outcomes. And crucially, improvement means having a culture where the organization actively learns from mistakes, near misses, and feedback, rather than hiding them or blaming individuals.
So it's about becoming a learning organization.
Precisely. A true culture of PSQ transforms a hospital from potentially operating in silos or a blame game mentality into a learning organization that is constantly seeking ways to become safer and better.
So how do hospitals practically build and sustain this culture of continuous improvement and safety? What do the PSQ standards require?
It starts, again, with structure and leadership. Hospitals must have a formally safety and quality program. This isn't optional. It needs a structured framework, often led by a dedicated PSQ committee and potentially a designated quality manager or patient safety officer. Critically, this program needs visible leadership support and involvement. They should develop an annual quality plan with specific, measurable goals, and leadership needs to regularly review progress and safety data. Safety and quality don't happen by accident. They have to be actively managed from the top down and bottom up.
A key part of learning is understanding when things go wrong. How do hospitals handle errors or adverse events?
That's covered under reporting and learning from events. This is absolutely fundamental to a safety culture. Hospitals must have a system for reporting all adverse events, things like medication errors, patient falls, surgical complications, diagnostic delays, and importantly, also reporting near misses, errors that were caught before reaching the patient.
And it needs to be non-punitive.
Ideally, yes. A no-blame or just culture reporting system encourages staff to report incidents without fear of retribution unless there is reckless behavior. The focus shifts from blaming individuals to understanding system flaws. For major adverse events, often called sentinel events, a thorough root cause analysis, RCA, should be conducted.
OACA.
To dig deep and understand not just what happened, but how and why it happened, looking for the underlying system factors or process failures that contributed to the event. The findings from these analyses must then lead to concrete action plans to prevent recurrence. Every mistake, every near miss is a powerful lesson, but only if the organization is willing to listen, analyze, and act.
And how do they track if they're actually getting safer or better overall? How do they measure progress?
They do this through systematic monitoring indicators and conducting clinical audits. Hospitals are required to define and track specific, measurable indicators that reflect their performance on key safety and quality dimensions.
Like the KPIs we mentioned.
Exactly like the KPIs. Things like hospital-wide infection rates, HAIs, patient fall rates, medication error rates per number of doses, rates of pressure ulcers, maybe patient satisfaction scores related to safety. These indicators should be collected regularly, often compiled into monthly dashboards for departments and hospital leadership, and trends analyzed over time. If you can't measure it, you really can't reliably improve it.
And clinical audits, what are those?
Clinical audits are more focused reviews of specific clinical practices or patient outcomes to see if they align with established standards or best practices. For example, a hospital might audit all C-section cases over a period to see if the indications met clinical guidelines. Or they might audit antibiotic usage patterns to ensure appropriate prescribing. The findings are then typically discussed in medical committees or departmental meetings, not to punish individuals, but to identify opportunities for improving clinical practice across the board. Audit isn't for punishment, it's for performance enhancement.
It sounds like listening actively to both patients and staff is also a crucial part of this improvement cycle.
It is absolutely essential. Patient and staff feedback must be systematically collected and, importantly, used to make meaningful service improvements. Hospitals need various channels for this patient satisfaction surveys, often given at discharge, comment cards or suggestion boxes, formal complaint management systems. Equally important is gathering feedback from staff through regular satisfaction surveys or forums, as they often have invaluable insights into system problems or safety concerns. The voices of patients and staff are like your compass. They point you towards areas needing attention and improvement.
And all this data from incidents, indicators, audits, feedback should lead to action.
Yes, it should fuel quality improvement projects. Hospitals should use the insights gained to launch structured improvement initiatives targeting specific problems or opportunities. For example, based on data showing a high rate of IV medication errors in the ICU, they might launch a project with a clear aim. Reduce 4V medication errors in ICU by 30% in 6 months. These projects often use formal improvement methodologies like the PDSA cycle, Plan to Study Act, to test changes, measure impact, and implement successful solutions. Continuous improvement requires continuous, focused effort.
And underpinning all of this is managing risk proactively.
Exactly. Risk management is the proactive side of safety. Hospitals need processes to systematically identify potential risks before they cause harm risks to patients, like falls, errors, risks to staff, like needle stick injuries, burnout, and risks to the organization's operations, like system failures, reputational damage. This often involves maintaining a risk register that documents potential threats, assessing their likelihood and impact, and implementing mitigation strategies or early warning systems. Safer systems naturally lead to safer outcomes.
Let's look at that concrete example from our guide again, the No Fall Zone campaign. How does that illustrate PSQ in action?
It's a perfect practical illustration. The problem was clearly identified when an elderly patient unfortunately suffered a hip fracture after falling in the bathroom. This adverse event was immediately reported through the hospital's incident reporting system and discussed in a safety meeting.
Okay, so it was flagged.
Yes. A root cause analysis, or at least a thorough investigation, was done, which identified contributing factors. The lighting in that ward's bathrooms was poor, and there were no grab bars for support. These were system issues, not just patient carelessness.
Finding the root causes.
Exactly. This analysis led directly to launching a focused quality improvement project, which they called the No Fall Zone campaign. The plan involved multiple interventions: installing brighter, motion-activated lights in bathrooms, fitting sturdy grab rails near toilets and showers, putting up clear visual signage reminding patients and staff about fall risks, and implementing hourly rounding by nurses specifically checking on high-risk patients' needs, like toileting.
Multi-pronged approach.
Yes, addressing the identified risks. They did implement these changes, the do phase. Then they studied the impact by closely monitoring the patient fall indicator specifically for that geriatric ward over the next 3 months.
And the outcome.
The outcome, the study phase result, was a remarkable 70% drop in the fall rate in that ward. Based on this success, the changes were fully adopted and potentially rolled out to other similar wards, the ACT phase. This entire process, from identifying a problem through reporting and analysis, to implementing targeted solutions through a structured project, and measuring the positive impact using indicators, is the very essence of patient safety and continuous quality improvement in action.
That's a really clear example. The guide also provides some more general insights into key performance indicators, KPIs, which we've mentioned a few times. Can you summarize what they are and why they're so crucial for measuring excellence in this context?
Sure. KPIs, or key performance indicators, are essentially specific, measurable values that reflect how well a hospital is performing against its stated quality, safety, and operational goals. They're fundamental because they provide objective evidence. They help track progress, or lack thereof, over time. They pinpoint specific areas that need improvement. They're often required to demonstrate compliance with accreditation standards like NABH. And, perhaps most importantly, they promote data-driven decision-making, moving away from guesswork or anecdotes.
The core principle being,
if you can measure it, you can manage it. And if you can manage it, you can improve it. KPIs turn abstract goals like improve safety into concrete, trackable metrics.
So how does a hospital actually use these KPIs effectively, and what kinds of things do they typically measure across the different chapters we've discussed?
Effectively using KPIs involves a cycle. First, define clear, relevant, and measurable indicators for each important process or outcome. Then, measure them consistently and accurately using reliable data sources. This might be daily, weekly, or monthly, depending on the indicator. Next, analyze the data, look for trends, variations, compare against benchmarks or targets. Based on the analysis, take action, implement changes or interventions aimed at improving performance. And finally, report the KPIs regularly to relevant stakeholders, including department staff and hospital leadership, to maintain focus and accountability.
And can you give some concrete examples linked to the NABH chapters?
Sure. For AAC, Access Assessment Continuity, a KPI might be average patient admission time or percentage of discharge summaries completed within 24 hours. For MOM, medication management, it could be medication error rate per 1,000 patient days or percentage of prescriptions with abbreviations. For PRE, patient rights and education, maybe number of patient complaints related to rights violations or percentage of patients receiving written discharge instructions. For IPC, infection control, common KPIs are HAI rates, like CLAB-BARS-I rate, CIUTI rate per 1,000 device days. For PSQ, patient safety and quality, number of reported sentinel events or patient fall rate per 1,000 patient days. For ROM, responsibility management, maybe staff vacancy rate or percentage compliance with legal licenses. For FMS, facility management, maybe average duration of power outages in critical areas or number of fire safety drills conducted. For HRM, human resources, maybe staff training completion rate or employee satisfaction score. And for IMS, information management, perhaps average time to retrieve medical records for emergency care or percentage of records found complete at audit.
Wow, that covers a lot. How do they make this data visible?
Often through dashboards. A monthly KPI dashboard is a common tool, visually displaying the key indicators for a department or the whole hospital. It typically shows the target, the actual performance for the month, and maybe a trend indicator, like an arrow showing if it's improving or worsening, or color coding, green for good, red for needs attention. Making data visible helps keep everyone focused.
And how do you build a culture where people actually care about these numbers?
That's key. Building a KPI culture involves several things. Clearly linking KPIs back to the relevant NABH standards and hospital goals helps people see the purpose. Displaying the dashboards prominently in departments encourages discussion. Involving staff and analyzing the data and brainstorming solutions gives them ownership. And importantly, celebrating improvements when targets are met or exceeded helps reinforce positive behavior. It's about embedding measurement and data use into the hospital's daily work rhythm.
This has been an incredibly detailed journey. We set out on a mission today to try and show you, our listeners, the often unseen architecture of healthcare quality. From that very first moment, a patient steps through the door, through every aspect of their care, and looking at all the complex management systems working tirelessly behind the scenes. We really hope this deep dive into NABH has provided that aha moment, revealing those intricate systems that are designed, or at least should be designed, to ensure every aspect of patient care is safe, effective, and patient-centered.
Absolutely. And it's become clear, I think, that NABH accreditation isn't just about following a set of rules or getting a certificate to display. It's fundamentally about building institutional habits. It's about embedding processes that foster trust between patients and providers. It's about creating multiple layers of safety. And it's about committing to continuously striving for excellence, one detailed process at a time.
Right. As the source material so eloquently put it, and it's worth repeating, quality in healthcare is not an act. It is a habit, built one process at a time.
Such a great line. It emphasizes that consistency and system design are key.
So, here's a final thought for you to ponder. Next time you, or perhaps a loved one, needs to step into a healthcare facility, maybe you'll think a little differently about what's going on around you. Knowing what we've discussed today, what specific signs of quality, maybe even those invisible ones related to process and culture, will you now look for or perhaps even ask about?
That's a great question to leave people with. Thank you so much for joining us on this deep dive today. We really hope you feel more informed and maybe even a bit more empowered about what truly goes into delivering high-quality, safe healthcare.
It's been fascinating. Until next time.